Now we're recording. So once again, I'm Lexi, founder and director of EMGLEX, and we're going to talk about neurologic disorders and Sweden today. So I'm going to hand it over to Ben, who's going to talk to us about strokes. Thanks, Ben.
Good morning or afternoon or in the middle of the night, depending on where you are compared to Chicago. We are at 11 a.m. now. I'm one of Dr. Azrael's partners here in the emergency department at North Shore. I'm honored to be asked to participate here. I'm actually the EMS medical director, so in the United States in various areas we have, it can be rather robust EMS services, usually fire department based. There are also hospital-based fire services and then private ambulances, so I'm in charge, the medical director of several fire departments, so that's my expertise. So please, if any of the items that I'm discussing, you're envisioning an ambulance component to it, I can certainly speak to that. I also understand that depending on where you are, where you practice, and the age of emergency medicine in your locale, some of this might be minimally, moderately, or significantly appropriate. So please, as an emergency room doctor, I'm used to interruptions, so this is informal. Stop me, yell, wave, clap, text, whatever. If I say something that's unclear or you want me to explain it, how it might apply differently in other locations, I'm happy to do that. All right, here we go. So stroke, I can already see that everyone on the call is already better than most of my colleagues when we do a lecture, especially virtual. The number of crying babies and barking dogs and breaking glasses, it's very distracting. So I already appreciate everyone being effective at muting their audio. But please pipe in with a question. Again, you can interrupt at any point. I have no financial, there you go. I have no financial association with the talk. Here's our quick outline. We'll talk some stats, how to recognize different types of stroke, measuring those strokes, who brings the strokes to what locations, and then how we actually treat them. It's going to be kind of quick and a high-level overview. I'm not going to get into too deep, detailed and specific topic, but if anyone wants me to add to the couple slides that we'll use to highlight each of the items, please let me know. Nobody likes stats, but it drives a lot of what we do. The bottom line is stroke happens a lot. Certainly in the United States, because a lot of us are,
better.
Oh my God, so great. In the United States, you know, the majority of us are overweight and don't take care of ourselves, so we probably have more than the most of the people around the world, but it's a huge problem no matter where you live. You can see all the number 1, number 5, all the statistics here. 1 in 3 Americans have vascular disease, so we see this pathology quite often. Important to recognize, and by no fault of their own, dispatchers, so 911, sorry, in the United States, 911, when you pick up the phone and you call for help, generally speaking, dispatchers are not medically trained. In some areas, it'll be an EMT or a paramedic, but in others, it's simply a non-medically trained person who is following protocols or items on a sheet. So you can imagine that capturing especially subtle presentations of stroke might be difficult. So half the time, the dispatcher will send an ambulance and a fire truck, for instance, saying ill person or sick person, and only once the paramedics get there, or even once they get to the hospital, do we recognize there's a stroke. So this is a big problem and one we're constantly trying to address. Here's a fact that I didn't really learn until becoming an attending. A lot of strokes happen when people wake up in the morning. And until fairly recently, these were largely ignored by emergency medicine doctors and neurologists. And I don't mean ignore in the sense that we don't pay attention, but the speed with which we intervened took a huge dive downward if the patient had a wake-up stroke. And that was largely due to the fact we'd use last known normal as the indicator of whether we're going to give something like TPA, like a clot buster. So if the patient goes to bed at 10 o'clock at night, wakes up at 7 in the morning, they can't move their left arm and their left leg, ambulance picks them up, brings them to the hospital. We say, when were you last known normal, or ask a family, when did you last see them normal? And they say last night before bed. Our level of haste will go down. That's no longer the case. So many strokes will happen in the morning. You can see 1 out of 5. And the reality is, because of some cortisol surges and sympathetic drive, these strokes are not really happening at 10:30 after you've fallen asleep. They're probably happening a half an hour or an hour before wake up. So there is significance to the change in pattern that we've now engaged these patients at the same speed and intensity that we would someone who had been awake and a half hour before in the afternoon develop stroke symptoms. So just a couple of the possible causes of why strokes happen with frequency in the morning. One, as I mentioned, we have this increased sympathetic surge as the sun is rising and we're waking up. I didn't know this, but apparently AFib, as we know, can be silent in many people, can have abrupt terminations early in the morning. And, though we'll discuss it a little bit later, AFib is one of the primary drivers of ischemic or clot-induced stroke. And the pathology there is blood doesn't like to be bounced around. The minute it slaps against a vessel wall, it engages a clotting cascade. So, which is certainly not rhythmic and will prevent the blood from flowing laminarly, one of my favorite words in medicine, laminar, so nice smooth flow down a tube. You have a fit, bounces the blood around the chamber walls, you form clot travels up the carotid into the brain. So when you shut off or on AFib, you increase the risk of clot formation, hence the morning time strokes. And then finally, for those who snore, which is probably most of us, you have some level of sleep apnea. That triggers a lot of hormonal discharges too. So another possible reason for 1 out of 5 strokes happening in the morning time. I'll pause for a moment. Any questions? What's going on?
They're done early.
We got a lot of our residents having just completed SIM conference here, and they're in celebration mode, so I'm sorry if you can hear the whooping and hollering in the
And you guys are next, so don't forget.
Okay, so recognizing stroke, this is not new to anyone. There are 2 primary types of stroke, ischemic and hemorrhagic. Ischemic is your clot type of stroke. By far, the majority of strokes we see are ischemic. Some of the risk factors, of course, high blood pressure, cholesterol, diabetes, smoking, and then again, AFib. Nothing new there. The other type, as we all know, is hemorrhagic. Oh, I'm sorry, before we go on. So I just have a little, for those on the newer side of medicine, I have a little cheat or easy way from across the room. You can see if someone's an AFib or not. It doesn't require any high-level engagement. Just look at the monitor. Watch this one on the left bouncing. And then in comparison to this, I think my beeps are not going to.
That's okay.
Yeah. So we're done. Left is AFib, right is something else. It's SVT, and they're about to shock that. So if you look at the monitor and you can see the heart rate swinging rather wildly, and we're talking changes of 10, 15, 20 beats, nothing else does that. That's AFib. So you can rest assured that that patient is now at higher risk for an ischemic event. So the hemorrhagic type is, of course, the bleeding stroke, aneurysms, hypertension. That's what will be the triggers or risk factors for hemorrhagic stroke. Now, the way that you can maybe ratchet up your suspicion when the patient comes to the ER, and even before CT, you're thinking, is this ischemic and do I have to draw up clot-busting medications, or is my suspicion higher? This is going to be the bleeding type. There are 2 good and reliable indicators that it'll be the latter, specifically severe headache, and then markedly elevated blood pressure. I'm not talking 160s over 80s. I'm talking 210 over 130. So headache, stroke symptoms in the face of very elevated blood pressure, that's almost certainly going to be a hemorrhagic type. So ischemic, AFib, hemorrhagic, headache, high blood pressure, really high blood pressure. I'll pause again. Any questions on the recognition? Okay. All right, this one, as an EMS director, drives me absolutely bonkers. There are so many different stroke scales. I can't keep track of them. Here are just some. I'm sure everyone here has heard of others. I know what we use in our EMS system, but the data is just so scattered on which one is best. And the moment you think you've confirmed one is better than the other, wait 3 months and new data will come out and it'll prove that it's weaker. So unfortunately, this is annoying. It is what it is. You choose which one you think is best for your system, you go with it, and you stick with it, and you ride the waves of the data nonsense. Right, frustrating. Regardless of what scale you use, there are really two things you really want to focus on capturing, and that includes the posterior type stroke, the posterior circulation strokes, and the large vessel occlusion, of course, the LVOs. And the LVOs are akin to a STEMI, so the number of chest pain patients we see is high, but not all of them have a heart attack. Well, the number of stroke patients we see are relatively high, but not all of them have an interventionable stroke. So the large vessel occlusion, the clot that plugs up a big vessel in the brain and needs you to pull it out, is akin to a STEMI in a heart attack. So if you think about it that way, that makes it a little easier. And the posterior circulation strokes, although they're a little tough, they're hard to uncover. They can be devastating. So you got to make sure you keep an eye out and a high level of suspicion. You know, the typical strokes we're talking about, mild to moderate motor sensory deficit, you have some language impairment and some memory loss. Those need attention, of course, but those aren't the ones necessarily that everyone jumps up and calls everyone and gets everyone involved. I don't know if we're going to hear audio on this now.
Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy rotation tonight. We had a very Darrison fight. Let's go ahead, Terrace Tracy, let's go ahead and pick.
All right. So now I have to be totally honest. This ended up being a complex migraine, but it's a great representation of a speech deficit, of course. So this is a productive speech deficit. She seemed to understand, so her receptive language is intact, but her ability to produce was not. My wife has been a teacher for 20 plus years. She teaches AP psychology, and she would be better here to describe the location in the brain that this is affecting. Wernicke's or Broca's, I can't remember, but there's something in the speech center that's being affected. So, you know, on a scale, she actually would not score very high. Her arms are working, her legs are working, her face is working, and it's just a small stroke in the language center, but this is devastating. So I don't mean to create gradations between these strokes. Even a small stroke can have profound effect, but this one particularly would not be posterior circulation, nor would it be a large vessel occlusion. So these drive us crazy, and they drive all ER providers crazy across the world, because the number of especially older people you get who come in with a dizzy complaint, in the world of emergency medicine, we all think of the worst case scenario. So you're dizzy, you're having a stroke. Well, 99% of the people who come in and are dizzy are vertigo. They're not having a stroke. However, it's our job to make sure we don't send that 1% home and now they can't function in life. Again, posterior circulation strokes are subtle, but we have to have a keen eye to make sure we capture them. So the posterior circulation stuff, usually cerebellar findings, that's balance, coordination, sometimes vision, usually diplopia, and it's binocular diplopia, not monocular. There's not much more to say about that. This is just tough. These are always tough. You're damned if you do, you're damned if you don't. You do too many tests to make sure there's no stroke, everyone complains you do too many tests. You don't do enough tests because you think it's vertigo, someone's going to complain that you didn't do enough tests. So we just accept our responsibility, do the best for the most people you can, try and come up with the best answer. Okay, so these are the big ones. So the large vessel occlusions, or the STEMI.
I have a question.
Yep, sure.
Go ahead.
Is that okay? Hi. Yeah, I'm talking about dizziness there. You name 4 points. If you have to, it's like you have to have those 3 points, like frequently miss it. Dizziness and vision failing. You have to have those two?
No, any. They can be in isolation, unfortunately. You can have a person coming with isolated, acute onset, binocular diplopia, and that can be their stroke symptom. They can walk just fine. So just to add to your frustration, it can be very subtle.
Yeah, we all hate dizziness. It's like taking a lot of time to a crowded emergency medicine. So emergency rooms, we have a lot of patients with dizziness, and they take a long time.
You're absolutely right.
Yeah. Thank you.
I hate when people come in with dizziness or something like subtle like this, because I just are we going to order an MRI on every single person who's dizzy from the ER? I mean, that's basically the only way to rule these out. So it's really frustrating. There's lots of videos online of like HINTS exam and other exams and things you can try, but I hate them also because they're garbage, personally, in my opinion. There's no true way to rule these out other than the test that rules them out, which is MRI. And so that's why this is so hard.
I will say experientially, so after 15 years of doing this, the few, and it hasn't been many, the few posterior circulation strokes that I've seen, the symptomology is more subtle, meaning they'll wake up, they'll walk, they're like, I feel just off balance, and they'll kind of lean, but it's subtle. They can more or less function. The peripheral pathology, the less dangerous, the vertigo, they're just laying in the bed. They don't want to move. They don't open their eyes. They're nauseated. They're vomiting. So it's rare in emergency medicine that the worse presentation actually equals lesser acuity. But you're right. I don't know if it's data-driven. That's my experience. So the strokes, the more subtle ones, the one you actually think I can relax because the symptoms are not super intense, those are the ones you go after. The really intense, I can't move, dizzy, vomiting, my vision's terrible, those are the ones that actually end up being more vertiginous or benign.
And do you have a neurologist working with you in the emergency department? Sorry, I missed the presentation. Or do you have just the emergency? I'm just saying just the emergency doctor because I became an emergency doctor just to avoid like a long examination. And you know what I mean? Or using my brain. If you understand what I mean.
My father was an internist, and I went and spent a little time with him when I was growing up, and I could not have been more bored. So emergency medicine was stay away from that. So the answer is, in larger centers, certainly academic centers in the United States, you'd have the ER physician in the department. A stroke would come in. Usually you hit a button, get the stroke alert going, and one of three things would happen. The stroke neurologist would call in. We have a discussion with them over the phone, or in some fancy places, we have video robots, so we wheel this robot and they can do what we're doing. The neurologist can zoom in. Or in the really large institutions, you'll have a neurologist in-house, and they'll come down to the bedside.
That's rare, I would say most places would be just you and maybe someone over the phone or video, I would say is the standard.
Understand.
Yes.
Yeah, thank you.
Great questions. Okay. Large vessel occlusion. So these are the devastating ones. And, without getting too bogged down with anatomy, one of three vessels are really involved, and almost, I don't know the percentage, it's high, is the middle cerebral artery. That's really your target. But, of course, the anterior cerebral or the posterior cerebral artery can be involved too. So large vessels are just what they say. A clot flicks up and goes into one of these big vessels, knocks out a large portion of the brain, so you have the associated significant deficits. And so why are these important? Because these are the ones that end people in nursing homes and on vents and all sorts of chronic, intense morbidity. Okay, so these are the two most reliable findings for a middle cerebral artery large vessel occlusion. Again, the most common. So an MCA large vessel occlusion, you will typically find these two things. The first is fixed gaze, and I'll embarrass myself with a video I took, and I'll show you exactly what that looks like. And the second is hemi-neglect. And for those who have not witnessed this, if you are not looking for it, it's missed. But when you find it, it's both fascinating and sad, but it's absolutely profound. So you will literally be on one side of the patient, communicating with them, and if their receptive language area isn't knocked out, they can actually respond, or at least look at you, or blink. If your partner or a nurse or a paramedic is on the other side talking to them at the same level, at the same distance, it's as if you're not even there. It's absolutely fascinating. That half of their world does not exist. And then their eyes will not cross the vertical midline when you're trying to get their attention. So your fixed gaze and hemi-neglect are your two most important features that should signify there's something big in a large vessel knocking out a large portion of the brain. All right, so as I said, I'm the EMS medical director. I lecture to paramedics all the time, and in order to keep them entertained, I will periodically embarrass myself so that they can laugh and learn better. So here we go. That's me in a wig, and then me not in a wig.
Hey, buddy. I'm EMS Fred. I'm with the fire department. Look at me, over here.
So watch the eyes on the right. No, it's okay. Okay, sorry about the echo. Sorry about the echo. So all we were trying to demonstrate there is the eyes will not cross the vertical midline no matter what you do on that side of the body. So there's your fixed gaze and your your hemi-neglect. Okay? I'm reluctant to ask questions on that one. I don't do any acting for fees. So any questions on the fixed gaze or hemi-neglect? Okay. So, of course, why are these?
Did they lose the ability to hear too, or just to cross the eyes?
You know, that's a good question. I don't know the answer. I would suspect they. Well, I will tell you, when I'm talking in someone's ear on their bad side, they will not respond. So I suspect then the auditory function's out too. That's a great question. I don't know.
I'm just thinking how that would work in the brain. I mean, yeah. No,
so if you knock out, if you knock out a large portion of the parietal and temporal area, certainly if it's on the left side, the speech goes out, the right body goes out. So I don't know, what's that, cranial nerve 8? I don't know where that. Gosh, that's resident stuff.
Yeah.
I'm out.
I would imagine,
it seems logical.
I would imagine that the actual nerves work, but the processing is not.
Right. That makes sense.
So that I think that you would probably, like physically, yes, could they physically hear you? Sure. But I would guess that they can't process it regardless. So whether or not it works or not, I don't think it matters. The functional capacity is that they can't.
Right.
Yeah.
All right. Here's another critical piece to why the recognizing LVO is so important. They do not respond to TPA. Actually, let me emphasize that. They do not respond to TPA. So whether it's the size of the clot that the TPA just simply can't bust or what, not only does the TPA not work on the clot itself, but these patients are at much higher risk for bleed conversion. So TPA has about a 6% hemorrhagic conversion when you give it. It goes up when you have a large vessel occlusion. Now, we don't have to deal with this topic in this lecture because it's new, but I don't know what the data is internationally. In the United States, there's a large push to switch to tenecteplase, to TNK. So I don't know how that'll look in terms of large vessel occlusion. I suspect not much different. The bottom line is these patients, like a STEMI, need a physician to go in and pull the clot out. Medicine's not going to do it.
These are scary. These are the ones that turn into bleeds, and just these are the worst ones I've had.
Right. Right. Okay. As we said, they need thrombectomy and they need it quickly. So just whatever intervention your hospital would use to retrieve a clot, that's what they need. So, and we don't want to do this. Right. That's the principle. Am I muted?
Yep, you're fine.
That's the principle of thrombectomy, just not through the mouth. Okay, moving on. This is the silly American humor. This is another key feature. 4.5 hours or sooner is the window for clot-busting medication. After 4.5 hours, again, Lexi and I, when we started our career, not in the too distant past, if they come in at 6 hours since symptom onset, we kind of say, I'm sorry, we'll admit you, there's nothing else to do. Now, if you have a large vessel occlusion or something amenable to thrombectomy, the data confirms that you can go up to 24 hours. So, for instance, our fire departments now, as part of their protocol, will come to the hospital with lights and sirens if the onset was within 24 hours, whereas before, if it was post 4.5 hours, they wouldn't come in what we call hot with lights and sirens because there wasn't a speed component to it. So this has been extended out for quite a long time, which is nice, and people can have a legitimate chance of meaningful recovery even if they've had symptoms for 18, 20, 22 hours. Okay, so this is going to be particularly unique, I suspect, to the United States, but I'm happy to entertain questions here. We have several levels of hospital status as it regards to stroke care. I'm just going to talk about the highest two levels, which would be primary stroke and comprehensive. You don't have to spend too much time on knowing the difference. The major component is the comprehensive stroke center can go in and retrieve a clot. That's it. There's all sorts of PT and follow-up staffing that a comprehensive center is required to have, but from an emergency standpoint, comprehensive equals clot retrieval capacity. Primary stroke center can give the TPA or whatever clot-busting medication, arrange for transfer if necessary, and send them to the larger institution. I'll pause because there isn't a whole lot else to describe from our standpoint, but I'm happy to entertain questions on what that looks like elsewhere.
Yeah, and maybe someone can chime in that's familiar with some of the pre-hospital, because I know in Europe, pre-hospital is a much bigger sort of part of emergency medicine, partially just because of geography and hospitals and, you know, how things are set up. But how does this compare to what you guys have in Germany or Sweden or anywhere else that people are on the call right now? About the same? Do you have different types of stroke centers, or is it just anyone, or how does that work?
Well, I can speak about Stockholm, and then I guess Nicholas can speak about Gothenburg, in Sweden at least. But we have the primary stroke center. Mostly it's just one big hospital here in Stockholm. And then you have always, sorry, we are talking primary stroke center in every hospital here in Stockholm. Every hospital has to be able to treat a minimal stroke. And then you have the comprehensive stroke center, which is just one of the 5 hospitals that we have here in Stockholm, at least.
Yeah. That sounds very similar, yeah. Like a hub and spoke model, basically.
Yeah, but I have a question about, I've been in States this June and visiting a hospital in Greenville. And I was amazed about the money that you spent. I mean, not you, but the patient have to pay. I have a friend who is a musician, and he told me that his wife has hypoglycemia. So the only thing that they got in the emergency department was a sandwich, and then they got a bill about $5,000 or something like that. That would never happen in Sweden. But how do the regular people do if they get a stroke there in States, and then you have to go to the comprehensive stroke center, but they don't have money?
Well, that's another topic that I think we'll cover at another conference. But the bottom line is there's different types of. No, it's okay. Most, at least older people over 65, have Medicare, which is the national government health insurance. And so since that's going to be generally the population we deal with, they do have insurance, which will cover anything that happens. The problem is because it's still a capitalist type of thing. If you have insurance or don't have insurance, they bill you a different amount of money. And depending on what insurance you have and what hospital you go to, there's a lot of complicated things that go into that. But I think part of it is because we have the emergency department is the only place where there's a law in the United States that says you have to get treatment. You have to have a medical screening exam and stabilization of any emergency condition regardless of your ability to pay. What ends up happening is that depending on what hospital you're at, a very large percentage of the bills never get paid at all. And so what happens is the small percentage of people that do pay the bills end up paying for all of the bills. And I think, a good number would be like 35% of bills getting paid. So 65% don't get paid at all. And that's a good percentage. Some hospitals that are like a county hospital will have like 15 to 20%. And so that's why they inflate the prices for other things to sort of cover the costs, because so little of it is ever actually reimbursed. Now, it's a very simplistic explanation, but we'll have a talk about that at one of the other conferences, because that's an interesting question.
I think the topic of that discussion will be nonsense, because it's embarrassing, it's shameful, it's broken. It's largely due to the insurance carriers and the legal system, and it's ridiculous. Is what it is.
Yeah.
It's broken.
Right, let's finish.
Okay.
We're gonna finish this lecture because we're gonna flip our schedule, just so you guys know just a little bit, because the residents finished early. So Nick, if you're okay waiting, we're gonna do a sim case next, and then have you go after that, because they're waiting for us. So we'll finish this lecture, we'll switch to sim, then we'll come back to this.
Okay, I'm almost done here. So we briefly touched on TPA, we've touched on thrombectomy, no need to rehash that. Blood pressure control, once again, this is a moving target, and you find data that seems confirmatory one day, 3 months later, it's changed. So a little bit loose, but the general principles here are to treat ischemic and hemorrhagic strokes, of course, differently. And as an easy recall tool, ischemic, you want to keep the blood pressure high, and hemorrhagic, you keep it relatively low. And of course, the rationale there is the clot will knock out the core part of the brain function, and that is not recoverable. However, we have multiple vessels supplying similar areas, redundancy, so there is an area in the brain that is threatened but not confirmed to be dead, so the tissue is salvageable. So if you do the right things with blood pressure management, you can have meaningful recovery from your stroke. In contrast, if, say, the pressure falls too low and you can't send blood through those compensatory vessels, then additional brain tissue will die, a worse outcome, higher morbidity, and higher mortality. And then, of course, like any bleeding at the body, around the body, if you're bleeding, you jack the pressure up, the bleeding will get worse. So you keep the pressure relatively low to stem the bleeding and hopefully allow clot formation. So that's not really helpful in a theoretical sense. The numbers we use will let the blood pressure in an ischemic stroke patient go pretty high. The nurses will come running to us and say, the pressure's 200 over 100 and the patient's having an ischemic stroke, and they're incredulous that we're not doing anything. The bottom line is you're actually helping perfuse the sensitive part of their brain. So once you get above 220 on top or 120 on the bottom, that's too high. And then the medicine we typically use is cardine, nicardipine drip. It's a fast on, fast off. It's easily titratable, so easy to work with. A hemorrhagic stroke, if the pressure, as we mentioned, if they'll come in with markedly elevated blood pressures, your job is to get that pressure down as quickly as you can. 140 is the target. I will tell you there's some data out there that says non-inferiority for 160. Some even say 180. At our institution, we use 140 as your target. So below those numbers is your goal. All right, here's your summary. The stats, it happens a lot. It's bad. We miss it. Keep an eye for wake-up strokes. They happen more than you think. Recognizing it, we have an ischemic event. AFib is your number one risk factor, and then we have a hemorrhagic type of stroke. If they present with severe headache and very, very, very high blood pressure, you suspect a hemorrhagic type of stroke. The scales, there are too many to comment on. Whatever works for your system, make sure you're capturing your large vessel occlusions, which can be indicated by your fixed gaze and hemi-neglect. And then, as it sounds like in several other areas of the globe, we have the hub and spoke model, which is the primary stroke center can give medicine, but then if you need someone to retrieve a clot, they need to go to a comprehensive center. And then blood pressure control. If it's a clot stroke, keep it high. If it's a hemorrhage, lower it. And I recognize that, especially for the residents, this is all overwhelming. I will promise you it gets easier. You'll gain confidence and feel better as you move into your career. Okay. Thank you, everyone.
All right. Thank you, Ben. That was awesome. We are going to rapidly walk over to the sim area. Yep, you can just sign out. And we're going to have our first sim case today, which is a demonstration for you guys from the University of Chicago. And nobody. Got it.
But I can do it.
Okay, well, actually, you're going to have a special treat because since the residents finished early, we will be doing an all-attending simulation case since everybody went home. Yeah. So, Chris, our sim fellow, is here with us again today, and he's going to help us run these cases. So, we did this last time with my phone, right?
Yes.
In the room?
Audio.
Okay. I'll leave this here for you guys. You can see what's going on. I'm going to get rid of this. Yeah, go ahead. Okay, let's take a 2-minute break while we get set up for everybody, and we'll be back in about 2 minutes, and we'll start the case. All right, everybody, we're going to get started. Oops, too much echo. Turn off this thing. We're going to get started. I'll be in the room, so we will talk and debrief afterwards. Okay, can you hear me? This is not the same room. Perfect. I'll press.
How's this for a sound check for everybody? All right, great.
Seems a lot better.
Good. Okay.
All right, let's get started. So, we are here today in the emergency department. We have Dr. Novak again, who helped us out last week.
Hi, everybody.
And where's the camera? And me. Hi. I'm the resident today because we don't have any, so.
I'm also the resident.
Oh, we're all residents. Okay, great. And I'm the nurse.
Yes, we're going to be the resident.
Awesome.
Chris is going to be our attending
Great.
instructor in the other room.
Okay, let's get started. All right.
So I'll lead if you would.
Yeah, sounds great.
So, hi, sir. Tell me what brought you in today.
I've been having a lot of pain in my stomach, kind of up here. Oh, and it goes into my chest too.
Okay.
It really hurts.
How old are you, sir?
I'm 65.
65. Okay. And you said your pain is kind of here, like above your belly button?
Yeah, right there.
And it goes up to your chest?
Yeah.
Okay, great. Can you put him on the monitor?
Yep.
And get us an EKG, please?
Yeah.
And we're going to need an IV line.
Oh, I'm really not feeling well. I feel kind of dizzy.
You feel dizzy? How long has this been going on?
It's about like an hour now.
An hour? What were you doing when it started?
Watching TV.
Watching TV? Okay. And can we get a blood pressure or what?
Yep.
So it's in the middle of the day today. Anything? Oh, okay. Have you ever had any heart problems before?
Yeah. Well, I guess I take an aspirin every day.
Have you ever had a heart attack?
No, I don't think so.
Okay. So we're getting you on the pad. We're putting some pads on you right now. I don't have a regular EKG on you, but what your monitor looks like your heart rate's going very fast and in an irregular rhythm called...
Yeah, that makes sense. I really don't feel good.
Have you ever had VTAC before? Does that name sound familiar to you?
Can you say that again? A what?
VTAC?
No, I don't think so.
Okay, because that's what you have right now. And your blood pressure is kind of low.
Oh, I feel it.
Normally what we will, can you start some IV fluids right
Yeah.
up for him? And then we send basic metabolic panel of magnesium and troponin and CBC.
Yep.
And then we'll need 2 IVs on him, please.
Okay. So I'll help with the IV on this side too.
Okay. So
I'm standing here.
your blood pressure is pretty low with this. Normally what we will do to reset your heart is to shock it, actually, with some electricity. Now, I would like to have you, to reset your heart, I would like to make you a little sleepy for that. We put on some oxygen, too.
Yeah.
So what I would like to do is give you a little bit of medication to make you sleepy so that it's not quite so miserable for you.
Oh, yeah.
And then we're going to shock your heart to reset it, okay?
Yeah, I don't want to feel that.
And did we ever get a regular 12 lead on him?
It's coming.
Okay.
You want nasopharyngeal or non-rebreathable?
Throw on a non-rebreather.
Okay.
Just a few more questions. So do you have any other medical problems or things you take medication for every day?
Yeah, I got diabetes and high blood pressure, and I think my cholesterol is high too.
Okay. Are you taking all your medications like the way you're supposed to take them?
Here's your 12 lead.
I mean, I think so. I have a lot of them.
Okay.
Is that
I think I got all of them.
currently?
Okay.
Because that's a big left bundle,
Yeah.
and it's regular.
Was this maybe when he came in, or is this just now?
Because that doesn't fit with what his rhythm is right now, which
Okay.
is fine.
Yeah, I think this might
Might have
have
been
been
when
first
he came in.
Okay.
Yeah.
So he's
I
a
saw
big-
him doing an EKG and triage, so that's probably what that is.
Okay. So he's
Okay.
a big left bundle branch block on this. Can't say much about it, but
Yeah.
um,
Do you have any allergies to medication?
can we get a glucose on?
No,
Yeah.
not that I know of.
Have you ever had surgery for anything in the past?
I had my appendix taken out when I was a kid.
Okay. Do you smoke or drink or use any illicit drugs?
I used to smoke a lot, but I quit 10 years ago.
Have you ever seen a cardiologist? You said no, right?
I don't think so.
No. Have you ever
I
had
see a lot of doctors.
Have you ever had a stress test?
Glucose is 120.
Where you
What
run
is-
on
what's
a
a
treadmill, you got to run on a treadmill and they check your heart out and do an ultrasound. Have you ever had that done?
Oh yeah, I had that done like 8 years ago.
Okay.
They said it was okay, I think.
All right. Well, I think we can go ahead and get you out of this funny rhythm now, okay? So we're going to give you some medication to sedate you.
So let's do we'll say he's like what should we say 70 kilos?
Yeah.
Okay, so we give him accommodate 10.
Sure.
So we're going to use Accommodate, which is a medication that's going to make you really sleepy for just a few minutes, okay? And then when you wake up, hopefully you'll be back out of this into a normal rhythm and feel a lot better.
Okay.
All right?
So I think we can just use 200 joules for
Yep.
this. Probably a little over what we might want to do.
So we're going to
You're going to hear some beeping and things like that, sir. We're not going to do anything until you're asleep, okay?
got the Accommodate. I'll
Okay.
put that in right away. Accommodate then. Okay? So we're going to go ahead and, sir, are you with me? Can you hear me? Okay.
We're connected.
Yep. Okay. Yep.
Oh, there we go.
Okay. So we're going to do a synchronized cardio version at 200
200
joules.
joules.
Everyone clear?
Everybody clear? All right, shocking. Synchronized.
Yep. Okay.
Shock delivered.
All right. Looks like we are in sign-in.
Can we have another, can we have a repeat EKG after the cardio version?
And blood pressure, please.
Yep.
We run the pressure.
Pulse, pressure.
How we doing, sir? Can you hear me? Are you with me?
Yeah.
Sorry if your chest hurts. So
How do you feel now? Is it a little bit better?
Yeah. I mean, I still have a lot of pain.
Sure. Okay. Well, we're looking at this EKG now that we just did after we gave you that shock. And I don't know if you guys all can see it out there, but it does look like you're probably having a heart attack, okay?
So
I think that's why you're having all this pain.
Heart attack?
Yeah, because you have high blood pressure and cholesterol, diabetes, and all of those are close, so those are all risk factors, and it looks like you haven't had a visit with a stress test or a cardiologist in a long time. So sometimes these things can kind of build up, and
Oh, jeez.
one day it just happens. So we're going to talk to our cardiologist and our cath lab team, and we're going to get you over there, and they're going to come and check out your heart and take out whatever blockage they need to, and we'll see how things go afterwards, okay? So a lot of things are going to happen really fast right now, and
Okay.
we'll try to explain it as we go, but we're going to take good care of you, okay?
Is there anything you can give me for pain? It's still
Sure.
hurting a lot.
Yeah, we definitely can now that you're out of that funny rhythm. So it looks like we've got a lateral.
I mean, I would say change to lateral.
Yeah. So why don't we go ahead and give some nitro?
Okay.
Give a sublingual nitro.
Hi, Dr. Novak from the ER. I have a 65-year-old patient here that needs a STEMI activation. His name is John Johnson, who came in with palpitations and chest pain. He was initially in VPAC. We did a sedated cardio version, and he's now in sinus rhythm with a rate of 80 with blood pressure cycling right now, but he's awake and talking and so forth. His EKG after the cardioversion showed probably an LAD lesion with ST segment elevation in 2, 3, and 4 with reciprocal changes inferiorly. We're going to give him some. We're going to load him with aspirin and Plavix, and anything else you'd like from us.
You guys can go ahead and start the heparin drip too.
Heparin drip, okay.
Yeah. And yeah, it definitely seems like we'll just bring him up. Yeah, you can admit under me, Dr. Hart.
Okay.
All right, thank you.
I'll bring him.
Thanks, Dr. Hart.
So, you 325 of aspirin, 150 of Plavix, and then I'm going to order a heparin drip also to get started. Okay, sir. We're going to give you some nitroglycerin also under your tongue to try and help your chest discomfort.
Okay.
We're going to give you some medications to thin your blood a little bit, and the cardiologists are going to take you to the catheterization lab to see if you need a stent, okay? That's a little procedure where they go in through the artery in either your groin or your wrist to see if they can open up the blockage that's in your heart. It's not a kind of get a big surgery through your chest, but that should really help, okay?
Okay, thank you for helping me out.
You're going to be admitted to the hospital. You're going to be admitted to the hospital overnight and probably for a day or two. Okay?
Okay, thank you again, doctor.
All right.
You're welcome.
Okay.
And it.
Cool. Thank you. Debrief time. Okay. All right. Oops, too much. Okay. Sorry about the fire alarm going off in the background. That was not part of the plan. So here we are in the control room of the sim lab. We have Chris. And we have our tech today.
Brandon.
Brandon,
Yeah.
right. He's helping us out with our cases today. So let's do a little debrief from the audience. So tell me what you thought, just initial thoughts. Comments, thoughts, impressions, questions. Okay, it was totally perfect, and no one has anything to say. Any criticisms, things you would have done differently, or things that you thought we did well?
Well, I do wrote.
I'll say some comments. Great to see you all, guys. Etomidate, I don't know many countries in Europe that have that, so.
Yeah.
Can you hear me?
I can,
so
yeah.
it's just just for all you guys out there, but it's a great choice, and I love the name Dr. Hart. For
we like that. So etomidate I know is a medication that we use a lot here for RSI and for sedations, but I know it's not something you can find in a lot of countries. So I know in Italy they don't have it. Germany I don't know either. I know you said you have it in Sweden.
Well, no, actually I wrote the question. What did you use for sedation? So that's why. So it's good that you.
Lots of choices that you can use for something like that. So what are some other drugs that you guys can think of that we could use for conscious sedation for either a cardioversion or reduction of a limb or something like that?
I missed the blood pressure. I couldn't see it.
It was 70 over 40 initially.
Oh, okay.
So what are some other options we can use for sedation other than etomidate?
I don't know. Propofol wouldn't be fine in this case, I guess.
Yeah.
What's that?
I'm so sorry. Oh, this is great.
Propofol wouldn't be fine, I guess.
So you could, yeah. We got our whole crew here.
Sorry, I thought we were debriefing in the other room.
It's okay. We just started. So we're talking about what medications we could choose for sedation because some countries don't have etomidate.
I think your priorities are pain relief, a little bit of sedation, and not dropping the blood pressure. I think ketamine would be another one.
Yep.
Although that is going to last quite a bit longer than you need for this. Ketamine is great for like
a 10-minute procedure, a laceration repair, fracture reduction and splinting. You guys have Brevitol is another one that lasts for just 2 minutes. That can be a good one. I think that's methohexatol. I think is the actual name of that. That could be a really good one. You could theoretically use Versed or I think that the trade name is
Midazolam.
Midazolam.
I don't know if that would be enough for a cardio version.
Yeah, the other problem with that is that can drop your blood pressure a little bit. Propofol also can drop the pressure a little bit.
Good choice if your pressure is okay or if it's high. Propofol is a great choice. But remember, propofol is sedation only, not pain. So if you're worrying about pain control for some other procedure, etomidate also is not for pain. So just to remember, for other procedures that might be more painful, like an orthopedic reduction, you want to make sure you have something for sedation and for pain.
Yeah.
And what about alfentanil, for example? Alfentanil or some kind of opiate?
Combining fentanyl with Versed or those kind of propofol or something is a good combo of sedation plus anesthesia or sedation plus pain management. The problem is combining those two things is going to severely worsen your blood pressure decrease. So I think ketamine is really the main one you're going to want to go to for painful procedures that are a little bit more drawn out. This, yes, it's uncomfortable and everything. I think the most of the patient's pain was probably from his actual underlying infarct, and getting some nitroglycerin and stenting and so forth would be where I would go with for that. But and there's been some recent data that opiates actually reduce the efficacy of the platelet inhibitors, specifically ticagrelor, clopidogrel, and their cousins. So our cardiologists really do not like us to use opiates in chest pain cases that are going to get a catheterization or admitted, frankly. So they tell us, like, either give them nitroglycerin or give them an apology. But for this, ketamine would have been a very reasonable choice. I don't think it would have. We always worry about creating tachycardia and worsening tachydysrhythmias with ketamine. But in this case, this guy's tachydysrhythmia was because of an infarct. I don't necessarily think that ketamine would have been bad for that. I like etomidate because a 0.1 per kilo dose of etomidate lasts for 3 minutes. There's very little blood pressure reduction, and they go all the way to sleep. I like it also for shoulder reductions. It's great for quick, it's gonna hurt, but it's gonna be very brief. Fracture reductions where you're manipulating things and it's gonna take 5 minutes and then you have to splint them. Really like ketamine.
Yeah, we used etomidate a lot in Germany, and it's come out of the shelf because of a side effect, the suppression of the adrenal glands. So yeah, it's a pretty rare side effect, but
So
our pharmacists think it's relevant, but we still give morphine to our patients with chest pain from STEMI.
Yeah.
And look, a lot of not alone. A lot of places do. It's still common here. I see it all the time. I would say personally, ketamine's great for kids. I agree. I've seen some adverse reactions in adults sometimes, and I've seen one particular case of very severe laryngospasm from ketamine that it was not like a young adult, but they dropped their sat to 50% and turned purple. That was terrifying. I have not had that happen in a kid, but I have seen it especially with adults, and then the emergence reactions. And sometimes with the adults, I find that the dosing is a little bit less predictable with ketamine for how long it takes them to wake up. which is why in a case like this, I would prefer etomidate or something shorter acting or more predictable, because I want this person to wake up. I want to be able to monitor them, and it's going to complicate things. If they don't wake up, I'm going to have to intubate that person to go to the cath lab. They're not going to let that person go like that. So that's a complication that you have to think about with ketamine in adults. I know it's been the big drug for the last few years and everyone loves ketamine, but there are downsides to it. So I just want you to think about other options and, think about reasons to use or not use a drug in a particular situation. I would say the one contraindication to etomidate that I do consider whenever I use it is if you have a patient with seizure history, you can't use it. It lowers your seizure threshold. So you don't want to use etomidate if a patient has a history of seizures. Other than that, there are very few contraindications. You don't have to worry so much about the blood pressure. You don't have to worry about any kind of emergence or longer duration of the sedation. So I really like it. Again, not great for pain control, but has advantages and disadvantages to everything.
Yeah, and just to put more info towards why etomidate would be bad for adrenal suppression, and the data is out there. The data is, to my knowledge, intubated patients with sepsis who had more than one dose of etomidate. So I don't know why I would give someone more than one dose of etomidate,
right, exactly.
to be honest with you.
Yeah.
But it was specifically in septic patients. And so they found that they had more adrenal suppression. So in this case, like procedural sedation for something like this, or a shoulder reduction or something like that, there's no data on it. Now, whether it's available or not available, it's not as though you can make an argument to a manufacturer that we want it in our hospital for these things, but I promise I won't use it in these other cases. That's not gonna do anything, right? So I think you're really thinking about which medications you have available. I don't think ketamine's unreasonable. I think Brevitol or methotrexate is another really good one for this kind of case. Versus, honestly, I would hesitate to give this patient propofol. I think that would give them enough propofol to sedate them sufficiently for this. Number one, it's going to last longer than you want, and number two, it's going to drop their blood pressure.
You're going to arrest.
So I think your other option is like a milligram of Versed or something like that, and then like an apology. I mean, I've said to people, I had a patient who was so sick. I said, look, you're in this rhythm, and I am very worried that if I give you anything to put you to sleep, your heart could stop. So I'm very sorry, but we just have to do this.
Mm-hmm. And that's okay. And in this case, it would not have been wrong to just shock this patient because he was unstable. His pressure was in the 70s. We could have just shocked him. Now, we're nice because we're American, so we tried to give him a little sedation. But it would not have been the wrong case to just shock the guy. I agree. All right. So any other for us or questions?
No, I know Sweden had a problem with etomidate because of studies with the adrenal gland, but these were mainly done in ICU settings, as far as I understand, and that was like a prolonged period of time they got it. So for one dose, it's not a problem at all. And but many countries still don't have it because of that.
Right. Yes.
Yeah, I couldn't agree more. And I don't know whether there were protocols written that, like for an intubated patient, they would be on a drip, some drip for prolonged sedation, something versus like a propofol or Versed and fentanyl drip or something else, and that's when they saw the adrenal suppression. And then that data got extrapolated to, oh, this patient got one dose, and we had to give them like 50 of hydrocortisone once.
Right.
So don't use this medication. That's incredibly useful. Okay, right? That's just. There's
a lot of good drugs that got pulled from the market because of stupid interpretation of data that was incorrect. Exactly.
The other important, really, really important part of this case that a fault that we'll sometimes see our more junior learners make with this is they try and treat medically. They try and treat with amiodarone, or they try and give a dose like 2 grams of magnesium over 15 minutes or something, thinking that will help this dysrhythmia. You could theoretically give those medications for this to someone with an adequate blood pressure. You shouldn't. if the patient's unstable, it's cardioversion. If the patient's stable, if we had the exact same rhythm, 180 beats per minute, irregular ventricular tachycardia, and they had a blood pressure of 125 and they weren't lightheaded and they were sitting up saying, yeah, I have some palpitations. It's very reasonable to give 150 milligrams of amiodarone over 10 minutes or half an hour and see what happens. If they become unstable, then you cardiovert them. But when they're already unstable, don't waste time with medications. You've got to cardiovert them because they will decompensate.
Okay. Any questions in general about the sim or the case or the sim lab or how we do sim or anything general for us? Oh, yes. Ketamine also increases the oxygen demand of the heart, which is not what we want. That is, yes, very correct. All right. Any other comments, questions about the sim in general or the case or anything else before we move on? Okay. So what I'd like to do now is, since we switched our order a little bit, Nick, why don't we have you do your talk, and then we'll come back after that and do the interactive sim. Christian, you are going to be in the hot seat, and if you'd like to pick a partner to help you do the case, you're going to be doing what we did from like a telehealth doctor, where you're going to direct us in how to do the case remotely. But we'll do that after the next talk to split things up a little bit.
Also, I do have a question there. I have to go and work after this. So how many minutes do you think? Well, it's 12 in an hour. I need to leave in an hour. Yeah.
Well,
I can continue with my phone, but I need to leave in an hour.
Well, why don't we do your case now then? And then is that okay, Nick? If we do the other case and then we'll come back to your talk? We'll just flip around the schedule a bit. Let's just do that. Let's do the next sim case now. And so do you have any colleagues from Sweden to help you be your partner, or do you want to pick someone from the audience to help you be your partner for the case?
Well, I take Nick, if he's okay with it.
Yeah, Nick? We got the Swedish team. Okay.
Now, I don't know if you guys want...
What's that?
I fell out for some reason. Oh, I just fell out for a few seconds. What's the next step, you said?
We're going to do the second simulation case. So you guys are going to do the case like we did, but you're going to do it from like a telehealth doctor. You're remote. We have a video in the room, and you're going to direct us for the case. Okay? So we are your hands, your eyes, your ears, and we're going to get started. So ask any questions. We'll try to speak slowly, and we'll see how things go. We'll do another debrief just like this afterwards. So here we go. Okay. You'll announce the case.
Sorry, the keys from the card.
Yeah.
Oh, okay. Okay. Is it muted? Just hit the mute button. Oh, there we go. Okay. Sorry.
Okay, we'll go ahead and start the case.
All right. Everyone can hear okay?
I can hear.
I can hear.
Great. Okay.
I can also hear.
Wonderful. So Chris is going to help us run this case today. We are here helping you, so let's get started. Chris?
Okay, so
yeah, so we are
who's a 22-year-old male who is coming in with some confusion.
Okay. So those of you in the audience, I gotta turn my speaker on. Go ahead.
So why is the patient coming? Sorry?
Confusion.
Confusion. Okay. Hello, sir. Can you tell me your name?
Yeah. Hi.
Hi. What's your name, sir? Do you know where we are? All right. Can we please take a look in the mouth of the patient? What do I see?
I don't see
if I look
anything.
into the mouth.
Nothing in the mouth.
Okay, the mouth is completely free. Awesome. Let's put the patient in the monitor, please.
Okay.
And let me count the respiratory rate. And let's see the oxygenation for the patient. And I want to listen to the lungs. Can you please listen to your lungs of the patient? What do I hear when you listen to the lungs?
Sounds okay, sounds clear, equal breath sounds.
All right. We have an oxygenation and respiratory rate, please.
Okay, coming.
Huh?
Kind of clear that.
Yeah.
Okay.
Not a big deal.
Okay.
Let's take our time because we're doing telemedicine. So.
Okay.
And
Can you see the monitor?
I see a 96. Is that okay? Yeah.
Pulse ox
95.
is 94%. Heart rate is 107. Blood pressure is 94 over 60. Respiratory rate is 60. And the temperature is 38, sorry. The temperature is 38.
38. Okay. Can you please listen to your heart and to the heart and give me the heart sound?
Sure.
And please, if you can do some IV lines and start to give some fluids of whatever you use in the States. I guess a ringer or a physiologic solution.
Sure. So heart sounds are regular. There's no significant findings on the heart exam.
Okay, let's go to D. Okay, please, sir. So can you tell me please your name?
Hi, I'm Kevin. I'm Michael's roommate. What's going on?
Yeah, just wait a little bit. We need to examine your mate a little bit, and then I'm gonna ask to you. I'm gonna talk to you. Is that okay?
Okay.
Just wait a little bit.
You said the blood sugar you wanted to see?
Yeah, I want to see the blood sugar, and then I want you to look in the eye and let me see how is the pupil.
Okay. So looking here, his eyes are kind of halfway closed. Kind of like not that responsive. Pupils look normal. Let's see if I can find a light.
Okay. So is he open here?
Your glucose
Sorry?
is 550.
How much is that in the Swedish? Is it high or low or normal?
Oh, what is it? Micrograms per deciliter here?
It's pretty
it's high. Our normal range,
Thank you, sir.
It's probably
normal
diabetic.
range is about 120, so 550 is very high.
All right. Can you just please draw some tests? And we need at least how to get an arterial blood sample or blood gas. Is that name in English? Yeah, and please. And let me know if you can.
What else do you want? ABC?
Sorry?
What else? What other blood tests do you want?
Well, what I want is if you can take some cultures too, blood cultures, and we need like leukocyte, hemoglobin, and TPQ, which is thrombocytes, I guess that is the name in English.
A complete blood count?
Yeah, thank you. A complete blood count, and then let me see if we can get some electrolytes too, and blood cultures. And it's pretty important for me to see the lactate. And then, and then can you please look if the patient has some kind of neck, how's the name when you can move your neck? Talking about meningitis, for example.
Meningism.
Yeah.
No, it seems okay. Maybe we should ask his roommate what happened.
Yeah, so tell me, now I can see what happened. You live with the guy, so what happened with him?
Well, we went to the game yesterday, and we had a couple of drinks, but I noticed that he was coughing a lot there, and he said he's been having a cough for a while, like a couple of days, and then this morning he just seemed like really out of it, and I figured maybe he's just had too much to drink, but then it kept going and he got worse, and I don't know, something is wrong. He's just acting really off.
Okay, it just became so he he was not normal yesterday, but it became even worse today, right?
Yeah.
So it sounds like he's
Okay.
been coughing for a couple of days, and then yesterday they went drinking, and then today he's really confused. Is that about right?
Yeah.
Okay.
Yeah.
Awesome. So 38 Celsius is what the temperature? How was the temperature?
38 degrees.
Sorry?
38 Celsius.
Okay. What do you think about to start giving some break spectrum antibiotic to the guy? I'm thinking about sepsis, for example, secondary to pneumonia.
Okay. Are there any other tests you want to order to look into that?
And do you say that he took some drugs? Is that right?
He was drinking last night, right? Alcohol?
Yeah, just like 2 or 3 beers.
Yeah.
I hear him
So
coughing quite here. I did hear him coughing a lot just now.
So we have high high glucose.
Mm-hmm.
Then he's coughing, and then we have loss unconsciousness or low GCS. Yeah, he's coughing.
Can we ask your friend there if he has any medical problems, medications, allergies?
Do you have any medical problems or take any medications that you know of?
Well, he keeps insulin in the fridge, and I think that's it. He has an inhaler also.
So we know he takes insulin. Okay.
So
we probably like blood cultures, urine culture, chest X-ray, EKG. You did order ABGs. We need a lactate too.
Yep.
You already started on fluids. You just have to make sure the bolus is good enough for his weight. And I'm gonna.
Yeah, we need to see I don't know the name in English. When you have a ketoacidosis, diabetes.
Yep. Beta hydroxybutyrate, the acetone level.
Yeah, acetone level. Yeah, thank you.
We can do that. Let's see if we have any results back.
I didn't hear that well, but
we have our ABG, our arterial blood gas is back. I'm going to hold this up if you can zoom in.
Yeah, what do you have in the pH?
So the pH is 7.06. The PCO2 is 26.
Yeah.
The PO2 is 90. The bicarbonate is 7. And the base excess is negative 22.
Okay. And how much was the lactate?
Let's see. Is that back? Yes. Lactic acid is 5.
Okay, minus 22 is the base excess. Yeah.
Yes.
So we have pretty several diabetes ketoacidosis here, right? Okay. So we need to start giving a huge amount of fluid to the patient.
I have your EKG too, if you want to see. It just looks like tachycardia.
3 to 5 seconds.
Yeah, let's take a look at the EKG. I have to tell you, this is really hard to see, but yeah.
It's kind of tachycardia. There's nothing that exciting. It just looks like sinus.
Yeah. So let's start giving some fluids. Do we have 2 IV lines? And let's just open the riddle and give fluids. And we need to measure the potassium and prepare potassium to the guy. And I don't know how you do in States, but in Sweden we don't give any kind of intravenous bolus of insulin. We just start insulin later. And then let me contact to the ICU doctor because I need to put this guy in the ICU. Do we have any trauma in the patient? Any concussion or?
No trauma. Just that his roommate said he was acting funny. So I have your chemistry results, your electrolyte. So your glucose is 550. Your sodium is 130. Your potassium is.
And the sodium 150. Yeah. Okay.
Normal range for sodium is 137 to 145, and yours is 130, so it's a little bit low. Potassium is 4, which is in the normal range. Fluoride is 5, which is normal. Bicarbonate is 4. Your normal range is 20 to 26. That's very, very low. Your BUN is 35, which is high.
Wait, Lexi, somebody's talking in the other mic. That's why. Sorry.
And creatinine is 2, which is also very high. Your magnesium is 1.5, which is slightly low. Your chemistry, that's your chemistry. Your blood count is as follows. Your white blood cell count is 16.2, which is high. Your hemoglobin is 14.9, which is normal. And your platelets are 772, which is very high. Your lymphocyte percentage is 67.4, which is very high. Let's see, what else? Elastic reflex. Okay.
Do we have any creatinine? How is the kidney working?
The creatinine is 2, so it's elevated.
Okay, let's start just giving the fluids, and please give me 2 or 3 liters directly. How much is the weight of the patient?
80 kilos.
Okay, start with 2 liters directly, like a bolus. And then what do you think? Sorry, somebody's talking at the same time in another mic. That's why I couldn't hear everything.
Sorry.
No, it's okay.
I think the control room is talking. The control room is talking. I think you're doing an excellent job. I think we did order some antibiotics, right, for his possible, and I would order some potassium right away. Because if we're going to start insulin drip, it's going to drop his potassium.
Yeah. So what do you have here? We have a cataclysmosis. We think that the patient perhaps is infectious. That's perhaps is the original. That's the reason why he has the cataclysmosis. I guess I don't know. We don't know. The patient cannot give any more information about that. Sure. And so we are taking the sepsis in the treatment.
Do you want to do anything about his fever, about his temperature?
Well, actually, the patient is not able to drink anything, and I'm not that a good friend with the paracetamol in IV, because I think that the blood pressure could drop there. So if it would be me, I just gonna wait. I mean, 38 wasn't that high, but I don't know. What do you think, Nicola?
What about
we can get some rectal.
Yeah, rectal.
Yeah, that's a good idea. Yeah, that's a really good idea.
So I have the ICU on the phone waiting to talk to you. They're on the phone.
Yeah, hi. My name is Christian. I'm actually a Swedish doctor working right now. And
this is Dr. Presser from the ICU.
Doctor, sorry?
Dr. Presser.
Oh, Dr. Presser. Yeah. We have a 22 male coming because of loss of conscience, fever. He's actually taking insulin, so we actually think that he's having some kind of diabetes. He's just 22 and he's not that big, so I guess that is diabetes type 1, but I'm just guessing. And it's actually the problem is that his glucose is very high. We have a typical ketoacidosis, and the patient has fever, was coughing a lot. So we think that the patient is in sepsis. That is the reason we are starting some fluids. We are giving antibiotics, and we are trying to take the fever down. And we are going to need to continue monitoring this guy.
Yeah. Why do you think he has a fever?
Well, sorry?
He wants to know why you think he has a fever.
Well, he was coughing yesterday, and the roommate said that the coughing was getting worse today. So we think that perhaps this could be pneumonia. So we're gonna do some X-ray for him but we are not sure that we are not gonna see anything yet. So let's see. We're gonna do an X-ray.
Okay. And do you guys started fluids and what else?
We started some fluids. We took lactate. We did everything that it says in in the 1 hour bundles, so fluids, lactate. We did the cultures and started the antibiotics.
Okay. Did you guys start insulin?
No,
Yeah, we did.
But
Oh, okay.
We started an insulin. But
Okay. Great. Okay. Yeah, sounds like he needs to be in the ICU. You can admit him under me, Dr. Presser.
okay.
yes, sir.
Thank you
Thank
so
you.
much.
Thank you. Bye.
Thank you. Bye.
And I think Chris,
Yes.
good.
Very good.
Chris. And Case. All right. Great job. I'm going to move back to the other room now. Here we are, back in the sim lab. Great job. Thank you. That was really good. So just tell me your initial thoughts. How do you think it went?
Well, it's not easy to do it in the teleconference, and of course there is room for improvement. But I guess that we could manage that patient without a problem here in my emergency room, at least.
Mm-hmm. How do you feel it went?
Great that you took the lead there, because I didn't realize who was going to sort of take the lead. But I guess in this situation, it's easier one person takes the patients.
Mm-hmm. Yeah. How do you feel like it went? Do you think everything went pretty smoothly, or would you change anything?
No. Well, what I understood is that it's really good to have people. In this case, Nicholas. Do you know that Nicholas is like a hero here in Sweden, right? For the emergency doctors. That's by the way. But it was really good to have like my senior with me, just giving some ideas and try to put me in the right path, you know.
Definitely.
So that was really good actually. And I guess that it would take the longest time if I didn't have the senior. Or when you are doing the E, B, C, D, and E, you are not seeing the whole picture. So perhaps it's good to have somebody else just looking at the whole picture, I guess.
Mm-hmm. Okay, Chris, you're our sim person.
I thought that went very smoothly. You guys got the vitals and the finger stick quite quickly, and honed in on the diagnosis of diabetic ketoacidosis quite quickly as well.
Mm-hmm.
And then, we always think about not only just in diabetic ketoacidosis, but in hyperglycemia in general, like why are they in this condition? And a lot of the times it's because they were missing their medications. In the U.S., unfortunately, there's a lot of patients who have trouble getting their insulin because of insurance issues. So unfortunately, that happens more frequently than we would like. Mm-hmm. But then oftentimes it's also due to infection, like in this case with the pneumonia. And then just some other things that we sometimes think about, not really in this patient who's so young, but an acute myocardial infarction, stroke, mm-hmm. that can also trigger this as well. But yeah, you guys got to diabetic ketoacidosis and pneumonia quite quickly. I thought it went really smoothly.
Mm-hmm. I have a question there. I was thinking about to cover all the stuff, so I was thinking about actually, I did think in my mind, do we have to do an X-ray or a CT scan in the head, or am I missing the third or the fourth diagnosis? You understand what I mean?
Yeah.
But I didn't express myself, so I guess that should be a room for improvement. Like say it in a loud voice, like we have to do something else. I'm missing something here. Yeah. What do you think about what is the fourth diagnosis that you have to rule out? Yeah.
I think that it was a little bit challenging just because we have so many layers of virtualness here. I did hear you say chest X-ray, and I think that would have been done, and that was okay. I think if it was in real life, it would have been a little bit easier. So, but you did mention it, so I think that was fine. But yeah, communication is the big thing you learn in the sim cases, and just getting comfortable with that, and speaking up if there's something wrong or if you need something. So that was one of the main things with this relatively complicated case, was just communicating well with the team and getting to the right diagnosis, which we did. So that was good. Yeah.
And I think you mentioned that the chest X-ray in some circumstances could be normal depending on how far along their disease process is. And typically what I've been taught is it takes about 2 days for abnormalities from a pneumonia to show up on chest X-ray. I don't think we gave you a specific time frame for this patient's illness, but I thought it was
2 days, I think, yeah.
Okay, I think it was a great point that you
You said yesterday, I guess,
yeah.
or something like that.
You did the right thing just doing the antibiotics, because even if the chest X-ray was negative, you'd still be giving those antibiotics.
Yeah.
Now, we didn't talk about choice of antibiotics. What would you choose in this scenario for your antibiotic coverage?
Well, actually, I'm actually in a little bit of bias there because I do research in sepsis. In this case, you have, I'm working with Karolinska Institute, which is, so I'm getting my PhD in sepsis, and actually in this case, I mean, you cannot rule out sepsis with this patient, with or without bacteremia. So I will always choose like a broad spectrum, like in this case, I would go for the piperacillin and tazobactam, for example. Okay, we know that the guy was coughing, but we know because of the other guy was telling us that we don't know anything about the patient because he's not allowed to tell us, I do have a pain when I pee, for example. Right. So the other choices could be like cefotaxime, which is a cephalosporin with how is the name in English? Cefotaxime and it starts with a G.
Gentamicin?
Yeah.
That's an
sorry?
option. Was it gentamicin that you're thinking about?
Yeah. Gentamicin. Thank you.
You have to be a little bit careful with patients with lower creatinine clearance, with any kind of renal injury or kidney problems with gentamicin. The other thing I would mention is this patient we think has type 1 diabetes, right? So that's going to put him at a little bit increased risk of atypical infections. So what would you use to cover your atypicals? And if you want to cheat, you can check the chat.
Well, in that case, I could use some kind of anti-mycotic too. Like I will add I'm just thinking the name in English, you know. But Nicholas can help me here, or.
I can help you. I actually know the American. Yeah. So I really know Swedish.
Well, so.
Sorry.
He wrote in the chat. He wrote in the chat ceftriaxone azithromycin, which is a good choice. So that's actually what we use here for uncomplicated. If it's not someone from a nursing home or that you have more concern about resistant infections, which is our first line for community-acquired pneumonia, is ceftriaxone azithromycin. So you've got your gram-positives, your gram-negatives, and your atypicals all covered with those two drugs. And so that's our first line. Now, if you have someone with known MRSA or VRE or Pseudomonas, you might want to change your choices a little bit. But so that's where we would start. If someone was, let's say, older from a nursing home or more sick, more like shock, I would choose vancomycin, right? And so those are the choices for like the big guns of patient is really, really sick and we're worried about resistant infections. They're, in septic shock. I would do vancomycin and Zosyn.
Yeah.
Okay.
Just thinking about Flagyl is the name in Swedish. Flagyl.
Flagyl.
Flagyl. Yeah. That's another option. We use that more for abdominal infections, but it is something you can consider.
Yeah.
All right. I want to wrap this up so we have time for everybody else's talk. So any other questions or thoughts or feedback for this case? Audience also? Anyone else? Okay.
I have a question. Would you study bicarb in this patient in the ER?
Good question. So I don't usually start bicarb unless the patient's bicarb is to the point where, we're talking about like someone who's intubated or someone who's a lot sicker. I think our nephrologists hesitant to start bicarb drips unless it's kind of a last resort. It's not something you start even just for this type of patient, because this patient just needs the insulin and the fluids, right? That's going to fix their pH and their bicarb for the most part. It'll take time, but we really reserve the bicarb drips for like a peri-arrest or arrest situation where it's much more significant. This patient had low bicarb, but not no bicarb. So when the bicarb's like 2, you might think about it. But you do see a bicarb of around 8 to 10 in a lot of these patients with DKA, and they do fine. All right, so let's switch over back to our lectures. Christian, I'm going to hand this over to you, and then we'll do Nick, and then we'll do our last special talk today, which is a treat from one of my other partners. But let's go ahead and get started, and let's try to have your talk done by, well, you have to go to work in 15 minutes, so you got 15 minutes. Go ahead and let's hear about Sweden, and then Nick will talk to us about Sweden as well and give us a little bit of a case.
Let's see now. It's who's doing.
Oops. You should be able to just present.
Yeah, I'm gonna enable sharing. To share your screen, please enable the recording. Yeah. Check. I'm just looking on why I'm not. Okay, here. Now you should see my desktop, I guess. Is that right?
Yep, there it is.
Yeah. I'm gonna try to prepare a presentation here. Sorry that
That's okay.
And then Nick, is it okay if I listen to your presentation in my way to the hospital?
Sure.
All right, guys, I'm going to try to keep it simple. My name is Christian. I'm actually emergency medicine residency in Stockholm right now. Well, I actually have just 1 month until I can send my papers to get my specialist degree. So this is my last 2 months as a residency. But we are going to talk about Sweden, and I guess, and I know that Niklas is also going to talk about it. I'm going to put you here. I don't know how to. All right. But Sweden, and it's a little bit of background that these specialties have been since 2006, and I guess that good for us. The guy who was the first specialist in Sweden is with us right now, which is Nicholas. Is that right, Nicholas? Right? You were the first emergency doctor in Sweden. Is that right?
Sorry, I was not the first, but it was another person.
Okay, but you were one of those first in Sweden, isn't it? That you were the first doctor in Island. But you can tell us about you, because I was reading about you at least. But since 2015 is something called a primary specialty. That means that you don't have to study you don't have to do another specialty in order to get, and then to study extra in order to get to be an emergency medicine doctor. Right now it's just a basic primary specialty, so you can just go through the training, throughout the training and get your specialty approved by the board. But as this 2021, just 47 of 67 hospitals. We have a total of 67 hospitals in Sweden, and just 47 out of those has emergency doctors or emergency doctors training. So a little bit of me. I'm actually from Argentina, living in Sweden, and I do work a lot with Spanish-speaking people too. I'm not doing only my residency. I do research in Karolinska Institute and actually working in sepsis. The name of our project is Sepsis at the Emergency Department, Improve Early Detection and Treatment. And that's boring, so I'm not going to be talking about that a lot. But Sweden has also his Society for Emergency Medicine that is growing. Or since it became a primary specialty in 2015, this society is getting more and more people coming in to them and working with them. You can be part of that, you can be a member, and you get a lot of extra, like a lot of courses and contact and network with other doctors. So it's good that we have this society because the specialty is growing, and this is the society that where you can become a member when you are a residency or a specialist in emergency medicine. And the name is SWESEM. So what I wanted to just talk with you guys and get some help and listen to your stories and how it's working in other countries is since 2015, when you do an emergency, when you are an ED doctor here in Sweden, you are actually trained into take care of the acute or ill patient, in the emergency department. And you are actually trained to work in the pre-hospital care and transport. So it's basically the same. The core curriculum is the same. Like you are trained to do the stabilization, the initial treatment, and even in case of disaster. For example, we did have a terror attack some years ago. You're supposed to be the guy who is trained to take care of these disasters. We did have a terror attack in Stockholm, and I'm going to be talking about Stockholm more because this is the capital of Sweden, and because I'm working here. And based on that terror attack, I can explain how the system works for emergency departments and emergency doctors here in Sweden. In Stockholm, you have 5 hospitals, which 4 of those are main hospitals, big hospitals. The main hospital and the trauma one center named Karolinska Solna, which is this down below here to your right. I was working actually, and I started my training in Karolinska Solna as an anesthesiologist. In Argentina, I was working with militaries doing emergency. Then I moved to Sweden, and I have to do my internship. I did my internship in Karolinska in order to get my degree in Sweden. And then I thought that I wanted to be an ED doctor here in Sweden as well. The problem is that when you work as an ED doctor in Sweden, you are not a real ED doctor, or you are not the ED doctor that you see in the States. So I thought, what is the closest specialty where I can get the training to be a real ED doctor? So I took an anesthesiologist residency place in Karolinska, which is the Trauma One Center in Stockholm. Then I realized after 1 year that it's fun when the trauma is coming, but then you have to be an anesthesiologist, and I didn't like that. So I actually moved to this other hospital named Hospital of the South, and at the end of my residency, I got a job in the 3rd hospital, which is St. Göran, where I'm working today. What is the difference actually? In the Trauma One Center, when you have a big trauma, which is Karolinska, you don't have any ED doctor working in the trauma. You have a surgeon, you have orthopedics, and you have anesthesiologists working with the patient. So big trauma, shotguns, or I don't know, multiple accidents, they come and they don't see any ED doctor. They have an ED doctor training, but they are not taking care of trauma in Karolinska Solna. So when you go to the Hospital of the South, which is this one, it was looking very attractive. They have just emergency doctor in their emergency department. But the last year they came with the conclusion that emergency doctors are not taking care of strokes, and they are not taking care of cardiac arrest. So if you have a patient that is coming with a cardiac arrest to the emergency department and you are an emergency doctor, then you are not taking care of the patient. So the cardiologists and their team are coming down to the emergency department to take care of the cardiac arrest. And so the neurologists, they thought, okay, we could do the same. So, okay, you emergency doctors, you can get the emergency department, but if we get a stroke or something in the brain, then we are coming down and taking care of the patient. So the emergency doctors, they just took care of, they were just working as a general practitioners with a little bit more training. So I decided to go further to another hospital where in the hospital that I'm working today, we have ED doctors training, but in the emergency department, you have all kinds of specialties working at. So the orthopedics go to the orthopedics, the surgeon go to the surgeon, and the medical intern go to the medical intern. And the ED can decide what you want to treat. So we take, so it's not always that an ED doctor is taking care of the trauma, for example. It could be a surgeon or it could be an orthopedic. So, and if we take care of if we look at this fourth hospital named Danderyd, which is a big hospital taking care of a lot of people, they don't have any ED training at all. So you don't have ED doctors in Danderyd. Sweden 2022, right? So what's happened for us as ED residency here in Sweden today is that a good ED doctor in Sweden must combine their training completing a second specialty. So for example, in my case, I did anesthesia, and now I got an offer to continue as an internist, in order just to get more experience, to be trusted as an ED doctor in our emergency department. So thank you very much. That was all, because the idea is to show how it works in Sweden and where we are today. Of course, that I can give you a lot of examples, but the airway is the big problem today, because our specialties start with a B and not with the A in Sweden. So it's a big challenging, because sometimes we are, yesterday I was working night shift until 8 o'clock today. And we did have a patient where the anesthesiologist was a guy he was really new as a resident in the anesthesiology department, but he's taking care of the airway in a very complicated patient, even if I had the training to do that and the experience. So he was really sad, actually. It ended with a fight, and we did call to his senior, who of course agreed with us. But so that is Sweden 2022. So welcome to Sweden.
Well, thank you very much, Christian. It was very interesting to hear about, and I'm sure as people watch this on the YouTube channel and get to look through your presentation, they'll see a lot of similarities with what I think a lot of people are dealing with in a lot of countries. And that was kind of what I was hoping for people to see, is that you're not alone. A lot of places are facing the same exact challenges and the same exact situation with emergency medicine being new or not recognized or newly recognized, and that's exactly why we're here. That's what EMGLEX is for. We're focusing on you and those places and trying to bring people together to work together to kind of, approach these problems.
Yeah, it was really fun, because in Argentina, actually, you could be like a real ED doctor, even if you didn't have the training.
Right.
So in Argentina, you were working as a new doctor, and you could take care of really ill patients without the training. Yeah. It was really, yeah.
It's definitely different everywhere, and so that's what we're here to hear about. All right. So thank you for your presentation. I appreciate it. I know you have to go to work, so we'll see you from the car, and I'll talk to you later today. Thanks. All right, Nick, you're up. Our celebrity.
Celebrity. Let's see if I can even work the computer. Let's hope so. Let's see now. Can you hear me?
Yes.
And can you see any? Should be able to see a presentation, maybe. Can you see any presentation? Yeah. All right. So I don't know how much time we have, by the way, because this is going to take like half an hour if I do both. Or
that's fine. We have a full hour left. There's one more person after you, and so he's going to log on soon. So yeah, we kind of got a small group here, so this is kind of a nice, intimate discussion where we can interact. And then again, this will be uploaded to the YouTube channel, so you will have a much bigger audience later watching you, as I'm sure a lot of people are working. So the floor is yours.
All right, thanks. So this is a case, I was going to speak something, neurology oriented. So this is a case I had like 15 or 16 years ago. And I'll walk you through it, and you can always comment and see if I could have done something better. I'm sure I could. But let's go. So I'm called, there's a female coming in, 31-year-old female, called in by EMS. Found roadside on the ground with her bike on the side. Helmet was off. And according to EMS, her speech was altered, possibly some right arm weakness or ataxic, and they think they checked the blood sugar, oxygen applied, IV established, 5 minutes ETA. And because of possible trauma, she was motion restricted with a spine board and collar and so forth. So she got into emergency department pretty fast. Her initial vital signs were fairly okay. Blood pressure 140/85, pulse 102, sat 96%, breathing okay, and temperature was normal. Patient was sort of awake. I know this is hard to sort of express when you're not there, but she was looking at me, but then not always seeing me, had sort of a drifting gaze. Did not actually speak any words. I don't know if she followed commands or not. I had a hard time to get a full neurologic exam. She was more or less moving all extremities, but maybe with some ataxia or not moving them, and I didn't know for sure if she could move them or not. Quick examination going through her body, cutting her clothes in case there was a trauma and so forth. We didn't see much of the traumatic injuries. No abrasions that could, maybe some dirt on her shirt and so forth, that like she'd be on the ground, but nothing more. And she was reported to be working as a dentist in town. She was healthy from the past. And so I don't know if I'll just wait for 2 seconds. You guys can think of what you would have done, what your differentials might have been, and plan of action. But anyway, since you can pause on YouTube and everything, I'll just go ahead and we'll see where it goes. So I ordered a chest x-ray, pelvic x-ray with the bedside fast. The nurse was working on IV access. We applied oxygen. And my gut thinking was something is going on in her head. And at the time I was working in a place where we didn't have neurosurgery, or we didn't even have a sort of a trauma system. We had a surgeon to call, but otherwise we'd have to ship that patient out, basically. So I was thinking I have to get a fast CT scan and see where this is going. And the CT head came back negative. Blood work was fairly unremarkable. EKG was okay, fast negative. Still has the same sort of symptoms, not able to speak, intermittent eye contact. So something was clearly off. Although she was hemodynamically stable, something was going on. So I just said this out loud, like, this woman clearly has something going on in her head, and what do you think? I asked my colleague, he says, she's broken out, and that was probably correct. So I got, at the time, we got the neurology involved for a stroke consult. We also had a hospitalist working there who would be doing the admissions. And all the other studies were pending at this point, but after discussing with neurology, we did actually give fibrinolytic therapy within the 3-hour time frame at the time when it was working. As you heard, it's, different time frames now. So this was actually a cerebellar infarct. They're around 2% of all ischemic strokes. Symptoms can be kind of, if they're more awake, they can say they have headache or dizziness, or you can see nausea and vomiting, but also vertigo, altered mental status, or coma. Coma is kind of unusual, but altered mental status you can clearly have. So this case was kind of a mix between altered mental status and, not really coma, but still severely affected. 90% of localizing signs like ataxia, dysarthria, nystagmus, and some of them actually have, the ones that have isolated vertigo, they're unable to walk. Many of them have direction changes in nystagmus. And causes are cardiac emboli, large vessel atherosclerosis, vertebral artery dissection, local arterial disease, so forth. I'll give you some links to read about this too. And 80 to 90% occur in the anterior circulation of the area, so to say. And actually, one interesting fact was also that a lot of these cerebellar infarcts occur after cardiac catheterization. I didn't know that, but it's an interesting point. So level of consciousness, if you have a deterioration in that, there's a strong marker for the clinical outcome. And the posterior fossa is space constrained. So basically, if you have a stroke that's evolving over time, you get edema, and you have to sort of do something about it. And usually you need prompt neurosurgical consultation. Either they would put in some kind of measure catheter, or actually go in and alleviate the pressure. And you can consider also mannitol or other measures depending on what you discuss with your neurosurgeon about that. I would do. Management, similar to stroke in general. Otherwise, you want to control the blood sugar, blood pressure, and so forth. And of course, CT contrast. Initially, this was to rule out any kind of bleed or a traumatic injury, but then you would likely have to go on with your contrast CT or MRI as per your institution, how fast you can get these things and what's available, and so forth. And considering this might need neurosurgical intervention, in a few cases you might consider heparin that can be turned off if the patient's risk for urgent surgical intervention. Usually that happens between the first day and up until a week or so. This patient had negative CT. MRI was positive for cerebellar stroke. And the carotids showed, I think, a left carotid lesion. I think it was the left side, yes. Cardiac echo was negative. And the last I checked, that was many years ago, of course. At the time, I was checking about several weeks after. Patient was not back working, but she was improving, so to say. Unfortunately, I don't have much more information about that. So basically, cerebellar infarctions. The symptoms can be pretty general sometimes. This patient didn't have much risk factors, but if they do, just push the diagnostics and get those CT scans with contrast or MRIs. And if you do an MRI, you should have the diffusion-weighted images that are more likely to show edema and so forth. And consider also neurosurgical intervention if the patient is decompensating, because they might have to do something with a ventricular drain or some kind of decompression. And also, if you are giving anticoagulants, you might consider heparin that you can turn off. So also, yes, I said that also endovascular treatment depending on the institution and resources. These days, you have to speak to neurology and neurosurgery because there's so many interventions that they can do, and it's quite, this is also an international audience, so I was thinking I won't go into that because it all depends on what you have at your facility and what time frame and so forth, but of course you're going to look into that. All right, so these are the references. Now, I can't see you guys, but does anybody have a question or comment or anything like that? And I'll take that. And otherwise, I'll continue with the Swedish emergency medicine, so to say.
Feel free whenever you're ready. We can take questions in the chat as they come. And
oh, yeah, that's a good point. All right, cool.
Well, I'll keep an eye on the chat for you.
All right, cool. So I'm going to talk a little bit about Swedish emergency medicine. Of course, it's my perspective. I'll just give you an overview first, and then I'll go in some of the positives and some of the challenges that we have. You heard a good presentation already as for resident becoming a specialist. So basically, 1955. Health insurance was government protected, so to say. You were insured by the government. Before that, everybody paid on their own. And primary care was the main sort of a health system that we had. We have hospitals, of course, with surgeons and orthopedics and so forth. And most physicians at the time were independent contractors, or had their own, a clinic or practice, basically. But in 1970, this was changed. The government took over healthcare, both financed and production of healthcare, or controlled it, so to say. And up to that point, a lot of specialists had actually worked in the emergency departments because that was a way of getting income. So in 1969, you'd have EDs most of the time staffed by senior physicians, surgeons, orthopedics, internists, and so forth. And then after 1970, it was not economically feasible to be there because you got a sort of a more of a salary that was independent of your performance or the number of patients you saw. So during the 70s, the specialists basically just abandoned the emergency department and worked more 9 to 5 and more in the hospital setting. And then to compensate for that, they just sent down the residents and interns to sort of take care of the emergency, especially off hours. And this was, of course, not the best solution. So Surgical Society was the ones that started discussion of having trauma doctors or ER doctors, or something more permanent and qualified, basically. And Swedish Society of Emergency Medicine was formed initially by internal medicine physicians, and a few training programs started in the year 2000. And then 2006, it was recognized as subspecialty, meaning you could add, after you did a regular 5-year specialty, you could do another 2-year emergency training, and you'd be dual qualified. And in 2015, it was recognized as a primary specialty. And just the numbers, we heard them already. I think I might be wrong on the EDs. It's about 65, depending on what you define as an emergency department, whether they have psych or peds and so forth. And it's over 2 million visits annually. So in general, if you're training residents or having any kind of residency training in Sweden, there's no body to govern the program. It's more or less regulated, or rather non-regulated. We review each other, but we have no mandate of telling somebody that you really have to improve, or otherwise you have to cut down the program or like close it or something. It's more like a honorary system where you recommend things. And people are, of course, quite compliant, but it's not as rigid as other countries have it. And the head of the department is responsible for residents and training, and they're also responsible for the health care. So these issues sometimes into conflict. Are we going to, train the residents, or we're just going to staff them to the work? And usually the training is a little bit lacking because of that. And we don't have external funding for residents. Basically, the hospitals, they used to be that they just hire residents as they need, more as a working labor, and then you get trained as you go along. And we don't have CME requirements for specialists. So we have a setting which is not optimal when you're starting a new specialty, because you don't have, layers of checks and balances that can help you. So the positives that I see over the last 20 years is that more training programs are developed. And there's also a strong interest from junior physicians. I get a lot of questions, and other people do, about emergency medicine. How can you practice it? It seems great. I'm all for it. And, you know, it is a nice job in that sense. And Swedish Society of Emergency Medicine, I think, has grown and matured and are producing documents and guidelines and trying to be a national voice. And we are more or less working nationally towards our goals. Now, that doesn't mean that all facilities or hospitals are sort of involved, but or working together. But we're growing and we're getting there, I think. And the challenges we have are, as I mentioned earlier, we evolved from a specialist culture since the 1970s, and even before that, hospital specialists have staffed the emergency department, whereas I think it's more of a generalist environment, more closer to primary care in a sense, because you're taking care of a whole patient or a whole population. And the hospitalist physicians, they have a team approach because they cannot take care of one patient all by themselves. They have to have the consults, and they take care of certain organs, or certain processes, or certain diagnostics. And their approach is team-based. And of course, our specialty is team-based with other healthcare providers, nurses, and techs, and so forth. But it's really a lot of times we manage patients as sole physicians, which is beneficial. And so this sets the environment for a conflict with a hospital-based culture. And I think even so, over the last 20 years, you can see like a lot of things have still been performed. Intubations, RSI, central lines, thoracotomy. I had a colleague do the other year, surgical airways, vaginal deliveries, lateral camphotomy several times, and so forth. So just by being an emergency physician, being trained, eventually, even if other departments sort of have the assignment to take care of it, we still get involved, and sometimes we still have to perform these things just because we're there and nobody is there to do it. And we have one facility, by the way, that has more a modern assignment system in place. And what I mean by that is the hospitals, the clinics in the hospital, like surgeons or orthopedists, they manage the patient from when they get to the ED to sort of when they leave the hospital. So they do all the admission orders, the next day ordering blood work, and EKGs, whatever they need. And whereas that's not really feasible for us because we need to deal with emergencies and then let the people, the patients who need hospital care and be taken care of by the hospital system. So we still don't have a clear-cut assignment or role as to what our role is or what our assignment is. And right now, I think I want to put this in a more positive way, but ED physicians are now growing. I think we're over 500 in the country. I think we'll need around we have to be 1,200 to 1,500 in total. And so we have a lot to say and a lot to do, but I think we still carry the culture of being more junior. So we have to do some growing there. Other specialties have their opinions about emergency medicine, but I don't think it's clear-cut anymore. 10, 15, 20 years ago, we met massive resistance from both internists, pediatricians, anesthesiology surgeons, basically everybody. And now I think it's a mixed bag. Like I don't see one specialty having a specific opinion. Like you can meet both opinions about positives or negatives with emergency medicine from any orthopedist or anesthesiologist or anybody. And at the same time, our own group now that's growing, we have also within ourselves different opinions as to should we do airways or should we not, or should we do pediatrics or not, and this and that. So it's the question has changed, and it's now, I think, more up to us. And the last pandemic that's been the COVID-19 pandemic, I think we got a sort of a boost there because suddenly the physicians from the hospital didn't like to be there or didn't see the need, and there was a great relief that we were there and taking action and leadership. And suddenly, from that point, I think people saw a benefit of having dedicated physicians in the emergency department. And I think everybody, both the emergency physicians and the hospital physicians, kind of liked that system. And I think one thing that's going to unfortunately help us if we have downturns in the economy, because the main benefit of emergency medicine having broad generalist physicians is cost effectiveness. You do get all the knowledge that you get right there for the patient from a medical point of view, but it's also cost effective. You don't have to have as many specialists on call. They can be maybe home and take call and come in for certain procedures and so forth. And I just put up a blood-brain barrier. I don't know if you have it in other countries, but we're in this hospital environment, we're taught that, you know, airway is sort of a different thing, an entity. So you can take care of almost a whole patient, but everything above the clavicle is sort of anesthesia and airway. And I think subconsciously we are taught that, and we teach our residents that, unfortunately. I think the awareness is a lot better from the junior physicians than from my generation, but it's sort of like it's just there. And I think it's inherited from hospital physicians who really don't take care of patients on their own either. They also use anesthesia for a lot of stuff, which is good for the planned procedure in the operating room, but less good from a logistical point of view. So right now, level of acute competence varies among emergency physicians in Sweden. I would say, you know, the very best programs, they are close to, you know, doing everything that, you know, an Anglo-Saxon physician would be able to do. They don't have it like they do it on a regular basis, but they're very good. And then, you know, you have to scale down the people who just started emergency training in their hospital, and they have, you know, no attendings, maybe 3 residents. Or you have another hospital where they assign somebody to be an emergency specialist by, you know, looking at the documents, their rotations, and somebody's just signing them off being a ED physician. So it's very variable, and it's all over the spectrum, and I anticipate that will be, you know, for the next decades to come, still a variation. And so possible solutions. I think we have to encourage people who want to be trained abroad, because you know, flying 10, 20, 30 years ahead or even longer is just it's a good experience. And we should also consider using foreign specialists in Sweden for short or long periods, or just shorter periods or longer periods. International exchange, as this is, I think is excellent. One focus I have, and I think we have in general, is to transform the emergency room to an emergency department, to define what exactly we're supposed to do. What are we supposed to do with our patients? What is our responsibility? And you know, extrapolate it to the 24/7, 365. Like, what can we do in a broader time frame or not, or throughout the day? And since a lot of specialists now do not have, you know, the full training that you'd get in a more mature country, I think we have to consider fellowships or a lot of training even for specialists. And I also want to say that the nursing also some or insight into, you know, emergency, even growing and all that people abroad nurse. And they don't know everything. And as I said before, if we can define the workload, so, you know, reporting and make sure the hospital specialists take care of the patients in a timely fashion, we make more nurses be involved, engage procedural health, more critical care submission. And because we need some effort in that, it's not just the physicians that can drive this development. And to summarize this, if it's a cultural change, it's cost efficiency, but it's also a culture of patient responsibility, not just organ responsibility or airway responsibility. And if we want to sustain this, I think we need more immersion, basically. So you have to dive into another culture or another setting. And yeah, I think I'll stop for there, because this is my last slide, I think. Yes, and I'm happy to take questions or comments. And yeah, thank you.
Very interesting. Thank you. I appreciate the in-depth talk about it. This is, again, another example of everything I've been saying, that we're all facing the same kind of challenges here. So, you know, we work together and we get farther. All right, I'm going to go quickly to Jake, he's our next presenter, and he's got to go soon to work. So Jake, I'm going to give you the floor, and Jake is one of my partners here. He's going to talk about a new device, which I think is really interesting, and I think this is going to be really cool for everyone. So Jake, you have the floor.
All right, hey everyone, thanks for letting me speak to you today. Trying to figure out how to share my screen.
At the bottom, there should be a button that says share, and then you can share your entire desktop.
Oh yeah, here. So it's making me do password. Okay, there. Can you guys see that?
Yes.
You guys can see it? Okay, great. Okay, all right. So I'm going to talk to you a little bit about a technology that we just rolled out into our ERs here. It's called BrainScope. And it's a pretty cool new device that essentially uses a point-of-care EEG technology to evaluate for the presence of intracranial hemorrhage as well as concussion. It's pictured up here on the right-hand side. You guys can see what it looks like. It's a handheld device that's applied to the forehead. It takes about 10 to 15 minutes to get run. It gives two results. It gives an indicator that looks for the presence of any traumatic intracranial hemorrhage. It also looks for concussion and grades that based on a percentile score. So this is, like I said before, is using a partial EEG technology to identify the findings consistent with concussion and also consistent with intracranial hemorrhage. This is a procedure that currently we're having our nurses and techs do in the emergency department on patients that we identify as being appropriate for this test. It tells us a couple of things. Like I said, it evaluates for intracranial bleeding. It has a sensitivity of about 98%, with it detecting as much as little as 1 milliliter of blood. The 2% that were missed were in the studies did not have any sort of neurosurgical requirement and were considered insignificant. And then we get this is termed a structural index classifier, which gives out three results: negative, equivocal, and evaluate. Negative is brain bleed is ruled out. Equivocal is unlikely to have a bleed, and then evaluate means that we need to move on to a CT for more testing. And then the other piece that we get is a brain function index, which diagnoses concussion, and it gives you a score between 0 and 100. And a score of 40 or less is considered to be concussed. And this is a pretty cool device in the sense that up until now we've not had an objective test that actually diagnoses concussion. It's more of a clinical diagnosis based on symptoms and exam findings. In the United States, it is approved by the Food and Drug Administration for ages 18 to 85 within 72 hours of injury. And we're talking about mild TBI patients, so GCS 13 to 15. And it can also be used on patients taking blood thinners or intoxicated patients, so there's a lot of potential uses there. We cannot use it on patients that have a GCS of less than 13. If there's skin injury underneath where we're putting the electrodes, if the patient can't cooperate, or if the patient, obviously, like we're concerned about a bleed, we're going to go right to CAT scan. We're not going to use this device before doing a CAT scan. We've been trying to target a patient population that's overall low-risk head injuries. We see a lot of patients that come in with headache after low-speed MVCs or overall mild trauma that maybe either are negative based upon like a Canadian head CT rule but still end up getting a CAT scan because they really don't have much else to offer, or who are kind of borderline based upon Canadian head CT or other decision rules, especially when it comes to mechanism. Our goals for implementing this device, and what we've actually already started to see a little bit, is reducing the number of CTs that are obtained on patients and hence reducing the radiation exposure. And also increasing our throughput. You know, here it's when we order a CAT scan, it takes time to get that test done. It takes time for it to get read by the radiologist, versus this is a 10 to 15 minute test that gives you instant results. And then we've also been working with our neurology clinic to try to get people follow-up after they've been seen in the emergency department and had this test done, especially those that appear to have a concussion. This is what the actual rule-out screen looks like on the device, and so this is for the SIC, the Structural Index Classifier, so the results will pop right up there, and the provider will get that result, like I said, after the test is completed. And this is what that brain function index looks like as well. And this is the one that's actually looking for concussion. It's a really unique device, and the rest of these slides are not pertinent to you guys. But it's a really unique device that I've enjoyed being able to use, and hoping is going to become more widespread. We're having more pressures put on us here in the U.S. by government agencies such as Medicare and Medicaid about CT scan reimbursements. And so being able to use a test like this to try to reduce CT scans has not only the benefit to the patient, but also benefit to us in increased throughput times and also reimbursement aspects as well. And I think that's about it. I'm sorry for the shortness of the presentation. I actually have to run because I'm about to go onto a shift. But Lexi, thanks for letting me share about this new device.
Thank you so much. That was awesome. And I'm guessing that this is, I don't know, you guys tell me out there if this is something you've heard about before or if this is something new. Those of you in Sweden and Germany.
Completely new.
Cool, right? I thought this would be a nice addition for you guys to learn something interesting and new that you don't get to hear about in a lot of conferences.
Yeah, maybe
all right, well, Jake,
internationally.
Yeah. I know you have to go, but we'll talk. Thank you so much for doing this. I appreciate it, and have a great shift.
All right, bye-bye.
All right. So we have a few more minutes for those of you that can stay. We can just have a little chat about kind of what we talked about today and answer any questions or comments or thoughts. And if not, we'll just end. So you guys tell me if you have any questions or want to talk about anything further. Nothing. Okay. All right. Well, thank you guys so much for coming. Again, this will be posted to our YouTube channel, which you can find the link on our website. And I'm sure we'll get lots of people that are working right now to watch it later. So this is great. We will have our next conference in October. And for those of you from Germany today, you guys are up next as Country of the Month. So we'll be talking about that. Our next conference is going to be, instead of the first Thursday, it's actually the second Thursday in October because the ASAP conference is the first week and everyone's going to be gone. So we will see you October 13th, same time. Link will be on the website for the next conference. And thank you guys all so much for your attention. Bye, everybody. See you next time.